There we go. Hello, everyone. We're going to let uh, everyone kind of file into the room, get their audio set up before we move into our session. This is where you need the little elevator music. Sometimes I do that. I just already have too many things pulled up on my screen today. Oh yeah, the number's still going up. So today is our Be Informed virtual education series. If you are looking for something else, you're in the wrong place, but you should still stay because this will be good. For those of you who want to, this is being done in a webinar format, but in order to really kind of push engagement, we do encourage our attendees to please use the chat box. This will be to both drop in like notes, but also use the chat, the Q&A window to type in your questions. We do want to get to as many questions as we can, so there'll be 2 different opportunities to get questions answered during this session. And please drop them in as you think about them. Some of the questions could be answered by Shreya or myself as we're hearing Dr. Graham continue or give her presentation. And we also like to, any questions that we're not able to field and answer, we do like to follow up and try to answer it. So I do know you can submit questions anonymously. You are welcome to do so. But if you do want an answer to your question for sure, throw your name on there and we can follow up with you afterwards. Okay. So a little bit about Hep B United. We are a coalition. I like to say we are a coalition of coalitions. We're a national coalition made up of smaller state and local coalitions that are really focused on tackling hepatitis B, and the organizations that are a part of it are either focus on hepatitis B as a specific infectious disease issue, or they are working towards bettering the health of a community that is disparately impacted by hepatitis B. So sometimes we have newer established organizations just getting up and running and really focused on hepatitis B. And we have other members who had been doing long time work in their community around high blood pressure or some other infectious disease and realized the need for hepatitis B screening, vaccine, linkage to treatment, that sort of thing. And started to build out that program. So we're here to help link those folks together and really do everything we can to provide them the resources and education and networking needed to increase awareness and linkage to screening and vaccination and care overall. And we do that through a variety of capacity building programs, including this one right here, which is the Be Informed series. So this is our 3rd session. It's every other month on the 3rd Tuesday at 3 p.m. So you can go right ahead and just start marking them out from here if you'd like. But basically, we wanted to be able to provide kind of more detailed information, but in an accessible way to folks who wouldn't necessarily have access to it otherwise, or it might not have it as easily. So providers use the kind of echo format to learn from one another, and we thought that format was good for learning for non-providers, for just a little bit larger audience. And so that's how we've been structuring these, and you see here on the screen kind of how these have gone. So our schedule, this first 5 minutes is exactly how I've just spent it. I'm about to turn it over to Dr. Camilla Graham. This says 10 to 15 minutes, but this is a little bit different than usual because Dr. Graham will be both our didactic speaker and our case study, because what she is presenting is particularly in depth. So she has quite a bit of time. But after the main session, we will do some Q&A and then dive into some case studies. And again, really heavily encourage folks to get involved. So, here we go. Yes. So without further ado, I'm very excited to turn it over to Dr. Camilla Graham, who is going to lead us in a conversation. Really, this stemmed from starting a conversation around provider engagement, and we've landed in a place of looking at that gray area with treatment guidance that really does exist and seems to be one of the key pieces along the continuum of care. And it's particularly important because I am not a provider, but I advise individuals who are trying to link people living with hepatitis B to providers, and they're going to have to describe treatment and like how that goes. And so, if providers can't figure it out, how are we supposed to have kind of the in-between people be able to figure it out? So I'm very excited for today's session and hoping that it helps advance our common knowledge. So Dr. Graham, I will stop sharing and let you take over.
All right, thank you. Let me, oh, that's not what I wanted to do. All right, let me just get into my right thing. And from the beginning.
All right, we see your slides.
Looks okay?
There we go. Yep, great, thank you.
All right. All right, so I'm super excited to be here today. And this talk is somewhat oriented to a US audience. I see we have an international audience here, but I will tell you some of what I am talking about comes from some work that I've done with an international working group. And I'm going to tell you the story of sort of how we got there, which has to do with a lot of frustration around how obtuse and complicated some of our current guidelines are for hepatitis B. So, as Frank just said, when providers are faced with guidelines around treatment that are confusing, it's going to make them less confident around screening for hepatitis B in the first place because, well, what do I do when I get these screening serologies? And what if I do find somebody who has chronic hepatitis B? And and what if I can't find a specialist that this person feels comfortable going to or is able to go to? And what if I don't know how to treat them themselves? And so really trying to figure this out is something that I've spent, I don't know, over 15 years thinking about. And I'm really excited that we've got quite a bit of momentum now on the recognition that this really is a kind of a health disparity issue. Now let's see. I've got my tool thing up and I don't want it right there because so Frank, I'm not able to move my slides for some reason. Oh, there we go. Okay, good. All right, no disclosures for hepatitis B. So the first thing I wanted to say is you when you're thinking about any sort of disease, it's good to have a North Star. It's good to have sort of what guides you. What are the principles that help you understand what you're going to focus on, how you're going to prioritize, what's right, what's wrong. And in a paper that I wrote with some colleagues a couple of years ago, including Sue Wong, that many of you may know, we really used this quote from the WHO on this idea of national treatment policies that recognize the barriers in access to testing, prevention, and treatment services, particularly among certain populations that don't necessarily have full access. And so when we think about guidelines, are we actually improving access to care with these guidelines, or are they actually barriers to care? So you all have already heard about this, but just to remind you sort of where we've been, people living with hepatitis B are at high risk of not being appropriately treated. So we think of high risk of liver cancer, high risk of cirrhosis, but they're also at high risk of not being appropriately treated. And I hope that's why you all are here today. So if 2/3 of people haven't been diagnosed, then you can't be treated if you haven't even been diagnosed. So that's a whole other initiative that's super, super important. But I'm showing you a study that might seem a little bit old, but it ended up being an important US study to understand the substantial gaps in care. This was cohort from a variety of medical centers across the United States, over 2,000 people living with hepatitis B, and just asked how well cared for were they. And what it showed was only a little over a third of these people with chronic hepatitis B infection had received at least one hepatitis B DNA test. And so if you think about the minimum monitoring everyone needs, this is not good. Um, Only 14% of people who also had cirrhosis had at least one annual liver imaging study that's supposed to represent imaging screening for hepatocellular carcinoma, liver cancer. That's also not good. And only half of people with cirrhosis and hepatitis B were prescribed antiviral therapy, much less people who didn't have cirrhosis. And the reason I focus on cirrhosis was even at that time, if you had hepatitis B and cirrhosis, you were supposed to be on antiviral therapy, and only half were. So we've got huge gaps in who's being treated. And this hasn't gotten better over the years. Now, I think that part of it is literally the framework we use to think about people living with hepatitis B. And you have probably seen this sort of transition map where people who've been infected through mother-to-child transmission go into this immune tolerant phase where they have high viral loads but normal liver enzymes. And then at some point, usually in their late teens, 20s, their immune system kind of wakes up and they go into an immune active phase. This is where people usually get much more interested in antiviral treatment. And then people can go into sort of this inactive phase. It's not really that inactive, but the immune system, that person's own immune system is doing a better job controlling it. And if everybody just sort of sat in each of those boxes, hepatitis B might be a little bit more straightforward. And you would think when you look at something like the AASLD 2018 guidelines, that most people probably do sit in a clearly defined immune tolerant phase, clearly defined immune active phase, clearly defined inactive phase, and that you should be able to very easily derive whether or not they need treatment based on what category. And that the categories seem like they should be relatively straightforward. And I think there's a lot of hepatologists that have not particularly recognized that when you look at this at face value and you think, well, this should be straightforward, so what's wrong with me that this is confusing, that they haven't made it apparent that over 40% of people, at least in the United States, don't fit into these clear categories. They're in the gray area. And so that's been the huge challenge, is that most people don't actually fit into the clearly defined categories that then lead to clearly defined action: treat, don't treat. Okay, and this is another way of looking at that same idea, where you've got people with varying levels of increased liver enzymes from less than the upper limit of normal to sort of in the middle to greater than 2 times the upper limit of normal. And then depending on whether they're hepatitis E antigen positive or negative, and I don't know about you, but most people I talk to don't really like to talk about E antigen. They find it confusing, but this guideline has it. You have to figure out if they're E antigen positive or not. And then from there, you've got different strata of what's considered a high viral load or a low viral load. And from there, you end up with 2 categories that are pretty clear. Treat this person with antiviral therapy. You've got about 3 categories, those kind of red categories that are pretty clear. This person needs to be monitored. They may never need treatment. They may need treatment at some point in the future, but for now, you're just going to really counsel them around. You're going to be monitored. And then if you look at all of the gray area, monitor, with the asterisks on it, this is where you're expected to do a lot of clinical judgment. You're supposed to assess for these individuals, do they have evidence of liver inflammation? No, inflammation is really only able to be determined with a liver biopsy, which I don't remember the last time I recommended somebody get a liver biopsy. Or they've got moderate or more severe liver fibrosis. And there's a variety of ways that you can determine liver fibrosis, including non-invasive serum markers, elastography. You've probably gotten talks about these to try to figure out how advanced somebody's fibrosis are. None of these are perfect. Age over 40, persistent ALT, greater than upper limit of normal. And this is important because that liver enzyme fluctuates. It's not like it's 60 and then it's 60, 60, 60, 60. It can be 60 and then 32 and then back up to 58. And if we're only checking liver enzymes every 3 to 4 months, maybe 3 times a year, what's happening the other 362 days when you're not actually measuring them? So another kind of complication. And the other thing you're supposed to do in all of these gray areas is make sure that you've excluded all other causes of elevated liver enzymes. Excessive alcohol use, fatty liver disease, autoimmune, other sorts of diseases like that. Obviously, the comorbid viral conditions like hepatitis C or delta hepatitis co-infection that you will have already tested for. So in any case, when you really read the fine print at the bottom of this particular guideline, it does point out that if you have somebody who's had persistent ALT elevations for greater than 6 months and are living in 2000 and greater than 40, that you can consider treatment. So lots of caveats, lots of things that you're supposed to check. And a group of us decided that this was contributing to the risk of inappropriately being treated or not being treated appropriately. Okay, and so part of the problem, we go back to this little schematic, is that people, this is a transition. Hepatitis B is a balance between the person with the infection, the host, the person who's providing the liver and everything for this virus to replicate in, their immune system, how well their immune system is reacting to this virus, and then the virus itself, which can mutate, which has all sorts of mechanisms to try to hide from the immune system. And this is a constant relationship that changes over time. That isn't captured in these guidelines. And I think that's part of what leads to these people being in what we call the gray area and some uncertainty around, well, does this person need to be treated or not? So a group of us got together basically because we all were frustrated with these guidelines, and we established some common principles. One was that whenever you've got guidelines that include a lot of people in a gray area, they are going to be confusing and hard to implement. Doesn't matter whether it's high blood pressure or diabetes, this is going to be true. And so most guidelines really work to try to give clear guidance for everybody, that's covered by that guideline. The second thing we realized, and this is a group of us from the US, UK, Hong Kong, Korea, that when we talked about how each of us actually managed people living with hepatitis B who fell into these sort of quote gray areas, we were all actually doing very similar things. We were all managing them in a very similar way. And it's like, well, why don't we actually make a guideline that's straightforward enough that community practitioners are able to follow them. You don't have to go to that tertiary care center, expert that aren't enough around for everybody who needs good care. So that was our goal. Make straightforward guidelines that do the best they can to eliminate the gray area. Now, there was some data that we used to kind of ground ourselves in what are we trying to do here. So one of them was we all agreed the data are very strong that an antiviral, here this study happens to be tenofovir, we get similar data with another medication like entecavir, reduces the incidence of hepatocellular carcinoma. And this is both true in cirrhotic patients, and this is in the upper right corner, where people without antiviral treatment have very, very high risk of liver cancer. And it doesn't go to zero. You still have to screen them for liver cancer, but it dramatically decreases if they're suppressed on antiviral therapy. And then in people who don't have cirrhosis, they still have a not insignificant risk of liver cancer. And the one thing you can do to decrease that risk is provide antiviral therapy. And then here's another study that looked at people who currently are considered to not meet criteria for antiviral therapy. These are these sort of minimally active individuals. That means their liver enzymes are a little bit up, but not substantially up, don't technically meet criteria for treatment. And what happens to them compared to people who did definitively meet criteria for treatment and were actually put on antiviral treatment? And you can see in the red and the orange lines that the people who don't technically meet criteria for treatment, but actually and are not treated, don't do as well in terms of developing cancer and a risk of bad things, death, transplant, compared to people who did meet criteria for treatment and were actually put on treatment. And this calls into question, does this classification of doesn't need treatment, what does that actually mean if these people actually are progressing and developing severe complications? That's the whole reason why you want to put people on treatment, to prevent them. And then this is another piece of data reviewed and thinking about the value of antiviral treatment. And what this did was look at the fact that hepatitis B integrates into the human chromosome. And its integrations can be in areas of the chromosome that could be promoter regions or suppressor regions. This is why it's an oncovirus. This is why it directly causes liver cancer, apart from its ability to create progressive liver fibrosis and cirrhosis. So most other liver diseases, you don't see liver cancer unless you actually have cirrhosis, like hepatitis C. You only really see it in people who've developed cirrhosis. But in hepatitis B, you can have people with mild liver fibrosis who develop liver cancer because of this cancer-causing quality of the hepatitis B. And this was a study that showed that even in people who are considered immune tolerant, typically those younger people with mother-to-child transmission, they are getting a lot of integrations of hepatitis B in their chromosomes. Imagine this is now setting people up for future development of liver cancer. Okay, so this was the schematic that we decided to put together. And what we did was we looked at the AASLD guidelines. We thought about all the things that we found were barriers to care in those guidelines. We looked at guidelines from EASL, that's Europe's Liver Society, APASL, the Asian Pacific Society. We looked at WHO, and we looked at the things that each of them had in common, why they had some differences. And this guideline actually is very close to the WHO guidelines, where we basically say if you are over 30 and have a viral load over 2,000, you need to be treated. If you have a viral load under 2,000, then you can be monitored. And then there's a little bit of a trick when you've got people who are those younger people under the age of 30, have immune tolerance. And I will tell you, we had a lot of conversations about the immune tolerant patient, that younger person, with on the one hand saying, we know that they are potentially having events that potentially could set them up for future liver cancer. Would there be a way to decrease that risk? With the understanding that these young people might be starting a treatment that they have to stay on for a very, very long time, and in assessing whether that's something that they're ready to do. And so that's kind of how we ended up with that little bit of a caveat around the under 30 people. But now I took that schematic and I put it in a similar table like I showed you with the AASLD to show you that basically there is no gray area. You've got the categories of people. If you're over 30 and your viral load is over 2,000, doesn't matter what your liver enzyme is, because we don't know what they're doing during all the time when we're not measuring them. You go ahead and start antiviral treatment. If they're under 30, but they're showing some liver inflammation, that liver enzyme is greater than the upper limit of normal, go ahead and treat them. And everybody else is monitoring. Now, how are you monitoring? Unlike that inflammation and something or another, and that whole laundry list, basically, if they're over 30, the reason you're monitoring them is because their viral load is less than 2,000, you're monitoring their viral load. And if their viral load goes above 2,000, well, now you know they've gotten into another category, a category where you would offer antiviral treatment. If they're less than 30, almost all of these people have a viral load greater than 2,000. So you're really not really monitoring that. You're monitoring that liver enzyme, that ALT. And if that starts going up, then they've gotten into this other category, and you offer them antiviral treatment. So I hope you believe that this is more straightforward than some of the other guidelines. Now, I hesitated to add this slide, but I'm going to share with you a bit of nuance. And what I want to emphasize is if you follow this, you are giving people very good care. No one is going to argue with you. No one's going to question, oh, why aren't you doing something or another? And you can feel very confident about it. And our belief is if everybody got treated under this, we would have a whole lot more people appropriately treated than we do right now, where we've got a lot of people that are not being, frankly, appropriately treated. Okay, but what about the people who they're age over 30? So they've often lived with hepatitis B for a very long time, and their viral load is less than 2,000. Is there some caveats and nuance, some gray area there? And I'm just going to share with you my personal philosophy, and the other doctors that were part of this working group kind of had a similar, like, these are things that are a little bit, again, they're a little bit more gray or a little bit more nuanced. And so one of them is just someone's personal preference. There are people who are like, I just don't like the idea that I've got this virus, replicating inside me. Maybe my viral load is only 1,000, but I would prefer to be on antiviral therapy. That is not the wrong answer for them to start them on antiviral therapy. You know that viral load measurements are not perfect. They're about plus or minus 0.3 logs. And so if somebody's viral load is 1,800, that could be essentially the same number as 2,000. And so somebody who's kind of sitting at 1,700, 1,800, they're near, 2,000, their liver enzymes, up a little bit. This is somebody you're probably going to want to start talking about the value of antiviral treatment. The non-invasive tests, the liver elastography, the fibrosis markers like FIB4, that you can calculate, they're not perfect. And so, if you've got somebody who's got very, very high scores, that's easy. They have advanced fibrosis. But there are people in kind of a gray area where you can't say they definitely don't have advanced fibrosis. And for those people, I'm going to err a little bit more on the side of, we can't exclude advanced fibrosis. Let's go ahead and start you on treatment. People with a family history of hepatocellular carcinoma are more likely themselves to develop it. And then this is a little bit of a subtlety, but if you do get a genotype on people, maybe you're trying to figure out if they developed resistance, or I'm not sure why else you would get it, but occasionally we will get genotypes. And if you see somebody has a basal core promoter mutation, and that will be clearly labeled on the genotype, those people have an increased risk of liver cancer. And I would be leaning more towards treating those people when they're in that borderline. Okay. Now, we've talked a lot about starting people on treatment. It's always important when you're counseling people to remind them about why they are taking this medication every day. These medicines, I typically use, I would do a lot of entecavir, but sometimes tenofovir. They're very well tolerated. They're great, powerful antivirals with a very high barrier to resistance. But that's what doctors and scientists care about. What we need to communicate to people who are living with this infection and actually taking this antiviral, is that this is the one thing that you can do to decrease the development of liver cancer. All that screening, the ultrasound every 6 months, that's to catch the liver cancer once it's developed. And hopefully if you catch it soon enough, you've got treatment options that are, a lot more effective. but it doesn't stop the development of cancer. Suppressive antiviral therapy is the one thing that can decrease that risk. Similar with risk of progression to cirrhosis, it decreases that risk of progression. It decreases the risk of needing to get a liver transplant. Most liver transplant programs have seen a substantial drop in the number of people requiring liver transplant for hepatitis B because of these very powerful, great antiviral treatments that we have available now. We're not going to talk about this in this conversation. It's probably going to be a different session, but it does reduce perinatal transmission in pregnant people. As a healthcare professional, I have colleagues who have hepatitis B, who maybe are doing invasive procedures like surgery. They can engage in their profession with hepatitis B, but they do need to have a suppressed viral load on antiviral therapy. And I'll get back to that one in just a moment. It may better position people for future curative strategies. I'm going to show you a slide on this because this is something that's really like where we're moving in the field, that I think is really, really interesting. How are we going to position the people we're taking care of today so that they are best able to take advantage of the amazing advances in drug development, going into the future? Reduce stigma. I've had a number of people say, when I have a suppressed viral load, I feel better about my situation. I feel more open about talking about it. And so, I think this is something that you can at least talk to people about. And then this last one, treatment is prevention. So in HIV, there was a lot of work that actually took a decade, to really establish undetectable equals untransmittable. It ended up being a really powerful message for people living with HIV. We've had a lot of conversations in the hepatitis B world. Can you say treatment is prevention in hepatitis B? People don't quite feel comfortable saying U equals U now, but just the examples I gave of, if you lower the viral load, you decrease transmission from pregnant people to their infants. People who have professions where they are working in invasive, things where they might cut themselves, like surgeons, decreased risk of transmission. You can go back and be a surgeon. We already accept and behave as if we know that it's true that a lower viral load decreases transmission. And I would like it if at some point we could make this more formalized. But I do include that in counseling as something that we don't have really strong data about, but that probably does have an impact. This is the table I picked looking at some of which are not currently active, but just asking, what requirements do these clinical trials of these new potentially curative therapies require? And most of them do require that somebody be on stable antiviral therapy. And a good number of them actually require that somebody be suppressed for a certain amount of time in order to be eligible. And so this idea that if the clinical trials are set up like this, if you want to be in the best position possible to take advantage of these new drugs in development, whenever they come out, I don't know when they're going to come out, 5 years, 7 years, be in that best position to take advantage of it. Now, I was asked to pause here. I don't know how I can. I don't want to make my screen blank. But I was gonna pause here and ask if people have any questions, and we're just going to do a couple of quick cases.
Yes. Does so we I don't think we have any open questions at the moment. Does anyone have any follow-up questions on what Dr. Graham has covered so far before we move into the case study portion? And as those, if there are any, get dropped in, I just want to say, Dr. Graham, if you can, you will occasionally your mic will cut out just a little bit. So just if you could keep like leaned forward or move your computer just a smidge towards you. I think it's when you like lean back a little bit, it like muffles it some. So.
Oh dear, I hope you were able to understand.
I still could understand you, and you never cut out completely. It would just get like soft and then come back into loud, and only for like a second or two.
Okay, I'll stay a little bit. I'll stay a little bit closer. Sorry about that.
No, technology. I don't see any additional questions. So how about you? Yeah, keep moving right along. We'll be able to use the rest of the time.
Okay. So yeah, what we can do is I'll go through these and I'm going to sort of talk through my thought process. I want you to be thinking along with me what you would do, and then we can leave a couple of minutes at the end if you don't agree with me or you have questions that come up with this. But this is basically like let's now sort of talk through what we. You know, I've got this bar that I really wish I could move out of the way, but I see. I see what I did. My screen sharing is paused. Resume share. Oh no. Are you guys, let me just, sorry, I just totally messed that up. Uh-oh. Oh, good. Okay, we're back. Okay, so this is a 52-year-old man. These are all people I've taken care of, so you can ask me questions about them. He's from Albania. He has chronic hepatitis B that was diagnosed about 10 years ago. And with each of these, I'm gonna kind of just for simplicity, um, act like I was checking people every 3 months. Everybody doesn't actually come back perfectly every 3 months, but just for the sake of discussion. Um, so this is somebody who's been undergoing evaluation. His liver enzymes, you can see here, I focus on the ALT because the AST can also reflect muscle. So the ALT for a man is within the normal limits. Uh, Platelet count, I'm including this because if somebody's platelet count starts getting around 150,000 or less, I start really worrying about cirrhosis. And that person to me is cirrhosis until proven otherwise. And then, so, really, completely normal platelets and a viral load that you can see is well below that 2,000 cutoff that we talked about, somewhere in the kind of the 100 range. And so, what are you going to do with this person? This is somebody that I think we would agree completely fits into that monitor category. And so, you're going to keep checking labs every 6 months. And by labs, really what you want to be checking is the ALT and the hepatitis B viral load. And I say every 6 months because this is somebody that you've established really has a rock normal liver enzymes, very low viral load. Um, they have about a 15% chance of at some point developing what we call immune escape and having that viral load jump up over 2,000. When that viral load goes over 2,000, what's happening is that they've developed immune escape. But what we care about is now that they've gone over that 2,000 viral load cutoff. And so that's what you're monitoring for. But until then, they should be they'd be pretty good. Now their age is over 40, and so you would screen them every 6 months for liver cancer. This is a person who has a very, very low risk of liver cancer, and I kind of wish that people would identify for us a group of people who are at such low risk for liver cancer that we don't bother treating them with an antiviral therapy, which I said is like the one way you can decrease the risk of liver cancer. If it's so low that you don't want to bother treating them with an antiviral, why are you screening them? I still puzzle over that. But the recommendations are to screen them, and that is what we do until somebody can give us data that says it's safe to not do that. Okay. Now, this is a 34-year-old man from Cape Verde who had his hepatitis B diagnosed about 2 years ago. And so again, we can look at these labs so that the ALT for this individual is elevated. For men, upper limit of normal is somewhere around 30 to 35, kind of depending on who you talk to. But once you start getting up into the 40s, that's definitely elevated. For the sake of hepatitis B, you need to be thinking that is an elevated ALT. But platelet count's normal, and that viral load is very low. And so this is one where you start thinking, why is this person's why do they have elevated liver enzymes? Is it because of this hepatitis B, because that viral load really is of somebody who's got pretty good immune control. What might be going on here? This is the person where um, you're really going to look for other causes of liver disease. And so hopefully you're routinely screening people for hepatitis C and Delta, but people can have hepatitis B and have fatty liver disease and have hemochromatosis. As it turns out, this gentleman went home for a couple of months, got in contact with extended family, and found out that lots and lots of people had what sounds like fatty liver disease. So thinking that that might be what's going on with his individual as well, and you would go down an additional pathway looking for that. Now, this particular person also raises the issue that we say normally start screening people for liver cancer at age 40 and older. Individuals born in sub-Saharan Africa, and I didn't have great data to say that Cape Verde Islands were similar, but I screened them in a similar manner. They have a high risk of developing liver cancer at unusually young ages. And so we usually start screening them for liver cancer in their 20s, because if you wait until their late 20s, early 30s, they can present with liver cancer. And if we have colleagues from sub-Saharan Africa, I'm sure they've seen individuals in their late 20s who have developed liver cancer, and it's heartbreaking. Okay. Case 3. I know I'm kind of running through this quickly, but I don't want to run out of time here. So this is a 44-year-old woman from South Korea. She was diagnosed with hepatitis B 20 years ago. Her mother also had found out she had chronic hepatitis B, so it's presumed mother-to-child transmission. And you're following her along, and initially her ALT is reasonably normal. Women, it's like 20 or less. At 6 months, you see that jumps up to 32. That's a little high for a woman, so you're starting to watch it a little bit more. And that jumps up to 42. That's definitely elevated for a woman. Platelet counts are normal. And then that viral load, which had been reassuringly low, suddenly jumps up to well above 2,000. And so what are we thinking here? So I never actually almost ever make a decision based on one viral load. I'm always like, did somebody else's blood get in here? Is it contaminated? Is this, a spurious result? I would like to check it one more time. And I like to give patients, time to sort of think about, I've been monitored. People always said, you're okay. Now suddenly somebody's saying something different to me. What does this mean? What are the implications? And so this is somebody I would bring back another time. I wouldn't wait 6 months. I'd bring them back in around 3 months or so. And if that viral load is still elevated, now you're really having a second conversation that says, this is a time when it might be appropriate to start antiviral therapy, because you're probably evolving into that different phase where the virus is now kind of getting out of your immune control and could start causing you trouble. And the best way to prevent that is to suppress people on antiviral therapy. And then because of the age, this person needs to be screened for liver cancer. All right. This is the last case. This is a gentleman from China who was diagnosed years ago. He thinks sometime in his adolescence. He doesn't think he's been treated, but he's not definitively sure he's never been treated for his hepatitis B. And his mother also has chronic hepatitis B, so he was probably, mother-child transmission as well. And so this is an individual. You might say, well, why are you continuing to monitor him? He was initially somewhat reluctant to think about antiviral therapy, and this isn't something that you're gonna push somebody, because all you'll do is likely make them either run away from you or get resistant. You want them to really come to their conclusion themselves. This is the choice I want to make to try to keep myself as healthy as possible. But his viral load, it does bounce around, but it is kind of trending upwards. And his liver enzyme is not particularly high. It's not particularly high, but and for ASLD, he would be in a gray area. But with the eliminate gray area, he's clearly somebody who falls into the needs to be treated. And so the little twist here is providers in China used a huge amount of lamivudine. I'm not sure if they're still using it that much, but for somebody who's been over here in the United States for a while, who was diagnosed in China, had some period of time in China with that diagnosis, isn't absolutely sure that they were never treated. I worry that those lamivudine sets up people for antibiotic resistance. This is why I don't treat it here. But our pressure. This is someone I can't actually see my screen.
Hey, Dr. Graham, the last like 5 seconds weren't hearable at all.
All right, yeah, I forget to. I need to like.
Oh, you're coming back in. Thanks. Yeah.
I'm sorry. Okay, so this is somebody who you may also be worried about more advanced fibrosis in. You've got a non-invasive test. This is a HEPA score, but you can use FIB4. That's within the range where you can't exclude advanced fibrosis, and so this is somebody that you would send for transient elastography if you've got access to that. To just truly try to define how much scarring they have and try to make sure that they don't actually have cirrhosis, because people with cirrhosis need a whole other body of care in addition to their hepatitis B to keep them healthy. Okay, that actually is my last case. And so I'm going to stop sharing. I'm going to try not to lean back again. And do people have any questions?
Yes, we have one, and it says, wonder why you recommend patients with chronic HBV and co-infection with HIV have consult with their HBV specialist in absence of other indications. Most HIV specialists are comfortable managing treating co-infected patients.
So I can't remember exactly how we said that. But yes, we did. Oh, so I forgot to point that out. So in a quarter, we have, if somebody has HIV, Hep B, Hep C, pregnancy, cirrhosis, I forget what else. Then if you aren't an expert in those areas, then talk to somebody in those areas. And so if you're a community physician and you don't take care of that many people with HIV, maybe you co-manage with somebody, a handful of people living with HIV, and now you get somebody who also has hepatitis B. This is one where you'd want to just check in with them. If you're a well-experienced HIV provider, absolutely. You've been treating hepatitis B. You know how to treat hepatitis B. Now, I will say there are data that show that HIV providers are not monitoring the hepatitis B part of somebody's co-infection as well as they need to. And I will tell you, I get, not infrequently a consult of somebody who's like, I don't know why this person's having this trouble. Can you take a look at them? I know they're taking their HIV their medications because their HIV is suppressed. Maybe their hepatitis B isn't fully suppressed. And it turns out you probably need much higher degrees of adherence to suppress hepatitis B than HIV. And they've allowed that person to sit with replicating hepatitis B. And so, I think we need to remind each other within the HIV realm, to be careful about screening for liver cancer, about regularly checking viral loads and ensuring that people's hepatitis B viral load is suppressed around the same time you're checking HIV viral load. And that's actually probably a completely different talk, but that's why that got on the list.
Well, actually, that was my follow-up question. Although we will gladly have you back for a syndemic conversation of incorporating all of this. But I was interested to hear. So I actually have two questions. One, what is your normal or current like 15 to 30-second pitch to patients on ensuring they go and kind of opt into some of these tests? That's one. And then the second one is, what is your pitch to providers to get them, providers focusing not on Hep B specifically, what's your pitch to providers to get them to actually start incorporating that liver cancer conversation, that vaccine conversation?
So what you're now talking about is how do you get people to screen? How do you get people to vaccinate? How do you get people to have reasonable conversations around hepatitis B care? I'm not sure I have a 15-second pitch for all of those.
Yes.
That's a very, very complicated question. But I mean, my pitch is, everybody needs to be tested for hepatitis B. And you're going to do the hepatitis B screen because we can all be categorized in terms of our hepatitis B status. And then if you find they have chronic hepatitis B, there's plenty of us that are very interested in providing care for them if that's not something you want to do. If that's something that you would like to do, or maybe because of your geography, you're in ECHO, you're going to take this on yourself. Keep availing yourself of the resources. There are people who are willing to, sit and answer questions. Hepatitis B is complicated. It's much more complicated than Hep C, much more complicated than HIV. There are a lot of nuances, and a simplified approach can provide very good care. And then just vaccination is just it's just like if somebody hasn't been exposed, just vaccinate them. Don't try to worry about risk factors and all of that. Yeah, but I think for patients, once we start moving into that realm of you may need antiviral therapy, and I never meet somebody and on that day say you need to start antiviral therapy. It's a conversation, it's a process. That's probably one that would be worth sort of a separate whole discussion. How do you counsel people so that they're really empowered to understand the value of this treatment for themselves, what it is they are achieving, and then and then hope for the future. And I think that this is something that a decade ago I hadn't incorporated into counseling, because it's like, hey, we got these antivirals, they do a pretty good job. I'm not sure what else there's ever going to be. That's not, we don't have curative therapy around the corner, but it's a lot closer than it's ever been in my career. And I'm pretty excited about it.
We are as well, and I am writing down providers empowering patients on their treatment. So I feel like that's a great webinar topic for the future as well. Well, thank you. We are just past our 50-minute mark, and we don't have other questions that have come up. So we will answer that one. Just wanted to get and say, Dr. Graham, thank you so much for taking the time to put together this presentation and then come and deliver it. We are very thrilled about the work you've done tackling it. And I actually just, it's funny that you mentioned the kind of, HIV providers making sure they're, familiar with Hep B care and Hep C care. I feel like you've been a longtime champion of syndemic care, and that's really where infectious disease is moving. So looking forward to continued partnerships in the future, and we'll get this recording sent out to everyone and posted soon.
Awesome. And just, I'm so grateful that there are people who, want to, learn more about hepatitis B. We desperately need, more people who want to provide good, safe, compassionate care for people living with this infection. And yeah, okay. So, Frank, if anybody emails you with questions that are like, can Dr. Graham, just pass those along. And I'm sorry I went in and out. I'm kind of in a bad space here.
You're good.
Hopefully you're able to hear enough to get the gist of it. Okay. Have a good day.
We did for sure. Thank you all very much, y'all. Have a great day.